to the Closing the Gap Network Plus Research Sofa. My name is Simon Gilbody. I'm Professor of Psychological Medicine at the University of York and Director of the UKRI Closing the Gap Network. This week, we have a special edition of the Closing the Gap Research Sofa because it's been a landmark week. Some data has emerged from Public Health England, and the headline figure is that it shows that the chances of someone with severe mental ill health dying before the age of 75 is around 3 or 4 times greater than for people without severe mental ill health. In order to understand that, we thought we'd invite someone who's thought very deeply about these matters over a number of years. So it's my absolute pleasure to welcome my colleague, Professor Rowena Jacobs. Hello, Rowena.
Hi, Simon.
Rowena, welcome to the Closing the Gap Research Sofa. To start with, could you tell me a little bit more about yourself and how you came to be interested in the health gap for people with severe mental ill health?
Yeah, certainly. Hello, Simon. I'm a health economist by background, and I actually trained as a kind of regular economist and rather sort of fell into health economics by accident, and then realized how interesting it was actually to focus an economic lens on the health sector, because so many things that economists think of in terms of how markets might operate really don't quite work in healthcare in the same way. So I decided to train further in health economics, and I did a PhD looking at efficiency and costs and performance measurement of health services. And what was really valuable for me training as a health economist was that we could use routine data, which is really collected for administrative purposes. So it's not collected for research, which makes it really inexpensive. And we can use this administrative data for research purposes. And we've developed really useful toolkits to try to interrogate that sort of data and use it to inform policy. And that's really what's driven me and interests me, is the use of the data, the linkage of data, and the economic and the econometric tools which we can use to try to answer policy relevant questions. So probably about 15 years ago now, I joined up with a number of other health economists at a workshop with policymakers at the time. And we spent the whole day discussing how health economists could address the most pressing questions facing the health service at the time, and also what data we could use to address these challenges. And we spent probably 3/4 of the day discussing acute physical hospital care. Then towards late afternoon, we moved on to primary care. Someone said, well, what about mental health? And the response at the time was, oh, that's just too complicated, too difficult. There's no data, let's not go there. And yet mental health was then, and still is today, the biggest program budget area of spend in the NHS. And it struck me this was really the area we needed to focus on the most, and which really demanded our attention as health economists the most. So I went off and got a postdoc fellowship and started working on the economics of mental health. And in the course of learning more about mental health care, I came to learn about this enormous health inequality that faces people with severe mental illness, with SMI, and that they die 15 to 20 years earlier than the general population. And it struck me that, well, amongst other things, trying to contribute to better understanding this gap and how we may be able to address this challenge was really important. And I think one of the things that for me is really interesting from an economist's perspective in looking at mental health, and especially SMI, is that the economic challenges are a bit different compared to physical illness, which by and large tends to affect individuals in older age, not exclusively, but to a greater extent. Whereas mental illness often presents for individuals during their working life, and that has economic implications in terms of things like people's employment prospects, their consumption expenditure, welfare payments, productivity losses in the economy, tax revenue, and of course, quality of life. So that's more or less the story of how I came to be focusing on this particular area as an economist.
Rowena, that's so interesting, and we've worked together over a number of years, and I've always been impressed about how your able to make sense of data that are collected on a routine basis and try to draw out policy implications and to give us advice about how we might re-engineer healthcare systems to help close the gap and to help reduce health inequality. So it was to you we turned when we tried to make sense of the public health data that came out just last week that have demonstrated these large health inequalities and gaps in life expectancy for people with severe mental ill health. So I'm hoping that you could tell us a little bit more about those data and why they are so important for helping us to understand the health gap for people with severe mental ill health.
They are really interesting. So Public Health England, their mental health intelligence network, developed these two new indicators on mortality of adults with SMI at a local level. So the first one is premature mortality in adults between the ages of 18. And what they mean by premature is people dying before the age of 75. So it's between 18 and 74. And then the second one is excess premature mortality in adults with SMI compared to adults without SMI. So the first measure, if you like, is an absolute measure of mortality and helps us understand where in the country people with SMI are at the highest risk of dying before the age of 75. The second one is a relative measure of inequality. So it helps us understand where in the country is the greatest difference for people with SMI compared to the rest of the population. So what they've done is they've used data from 2015 to 2017. So it's not the latest available, but they do have plans to update this to look at 2017 to 2019 data in due course. And they use local authorities as the unit of analysis. And what they do is they take data from the Office for National Statistics, ONS deaths data, and they link this to a routine administrative data set called the Mental Health Services Data Set, or MHSDS, and its various predecessor data sets, which had lots of different names over time. And this is in fact one of the key administrative data sets which we also use a lot in our research. And it captures everyone in contact with secondary mental health services in England. So whether you're in the community or an inpatient, and all mental health trusts have to submit data to the MHSDS. So Public Health England's definition of SMI is an interesting one. It's not the one we usually use, but they define it as anyone who's been captured in secondary mental health services, so in the MHSDS, in the 5 years prior to them dying. And the reason they use this definition is it's very difficult to narrow down specific conditions in the MHSDS because diagnosis is unfortunately really poorly coded. And we have actually, in fact, been working on an algorithm to try to identify people with psychosis in the MHSDS for exactly this purpose, because it doesn't currently exist. So using this definition and these linked data, they show two really quite startling things, as you alluded to. The first one is that in England, people with SMI are more than 4.5 times more likely to die young, i.e. before the age of 75, than those without SMI. And also, the second one is that there's no local authority in England where people with SMI are either equally or less likely to die than those without SMI. So I think really quite startling figures that they've demonstrated by linking these data.
So as you say, really quite startling figures. So I guess the next question would be, how might we use such statistics to try and begin to close the gap for people with severe mental ill health?
Yeah, I mean, comparative statistics can be really powerful, and indeed these ones are really stark and just highlight the immense challenge that lies ahead to address this inequality. So what you can do is you can go onto the Public Health Outcomes Framework, their website for Public Health England, and you can compare statistics across local authorities to that of England, the national average. And in time, you'll be able to also compare these across NHS geographies. And we know that this kind of comparative data can be a really powerful lever for change. So we've seen in the past, for example, with breast cancer mortality rates, where countries were league tabled and compared. Nobody wants to take the bottom spot. And that really drove significant improvements in early screening and other areas in England. So using routine data in this way can generate a tool which enables comparison across localities and can be hopefully a strong motivator to support change. However, your unit of analysis needs to be the right one. So it needs to be the organizational unit that can actually exact that change, that can make the change. So developing these statistics across both local authorities and NHS geographies makes sense, because we know that a really large component of what drives this premature mortality is preventable physical illness. So we know people with SMI are more than 3 times more likely to have physical health problems. So if NHS organizations use this toolkit, they can then potentially measure the impact of any interventions that they might implement to try and improve this premature mortality. So for example, trying to incentivize people getting physical health checks. But we also know that a really large component of this premature mortality is driven by factors outside of the health service. So social factors, things like poverty, homelessness, unemployment. So therefore measuring these at a local authority level is also important. So these data are really valuable and could potentially in time help us show if we're having any success at reducing these inequalities, whether it's through tackling it through the health service or through some of these broader societal solutions.
Now that's really interesting, and I guess that leads naturally onto my final question. So Rowena, we've worked together over a number of years and we're colleagues in the Closing the Gap network, and people might not know that you are the lead for our big data theme within the Closing the Gap network. So my final question is, could you give me some examples of the work that you've done over the past few years and how that work of your own might help us to close the gap for people with severe mental ill health?
Yeah, so as I mentioned before, I think, well, my interest is in the use of data, big data, the linkage of data, and the economic tools that we can use to try and address important policy questions, such as how to reduce the mortality gap. So all of the examples of the kind of work that we've been doing is really doing just that. So for example, we've had a project looking at how better quality primary care could potentially improve outcomes for people, such as ensuring that everyone with SMI who needs one has a good care plan, or that they experience continuity of care, so they see the same GP over time. And we've shown that that can lead to better health outcomes and indeed reduce costs for the NHS. And that particular project required really complex data linkages across the whole patient care pathway, which is the first time that had ever been done in England. But we're also looking at how we might incentivize physical health checks and who receives them. Another piece of work is looking at whether individuals with SMI and diabetes are less likely to receive health checks for their diabetes. So for example, their blood sugar monitoring. Another project is looking at examining the risk of hospitalizations for potentially preventable conditions for people with SMI to try and understand what those contributory factors might be. So a whole range of different projects along that sort of theme. And we've also been doing some work around linking information on the natural environment with the prevalence of SMI. So we're looking at linking health records data with data on green and blue spaces, air and noise pollution, flood risks, along with, of course, measures of socioeconomic deprivation. So we can try and understand how these relationships vary across England and in different urban, rural contexts. And that again might help inform policy about potentially nature-based solutions to improving health, or green prescribing, or urban planning, and so on. So I think there are many exciting opportunities that exist to exploit big data. The linkage possibilities are always increasing. Our computer processing capacity to manage these data are always growing. And I think our economic toolkit and our econometric methods are also expanding, so we can better interrogate this data. So it's exciting to see this field of mental health economics growing and working alongside other disciplines to try and make a difference to some of these really important policy questions.
And it's been an absolute pleasure to work with you over these years. And I've always been impressed by the innovative ways in which you use methodology, interrogate complex data sets to come up with really clear messages for policy and for practice. So thinking about your example of the importance of continuity of care, for example. So we're really looking forward to continuing to collaborate and to work with you within the Closing the Gap network for years to come. And it just falls to me to thank you for sharing your insights about this important new data release from Public Health England and also discussing your work. So thank you for speaking to us today, Rowena.
Thank you, Simon.